Vanita Noronha. I'm a medical oncologist at Tata Hospital. So these are my disclosures. I think all of these are for phase 4 studies. But I think the most important disclosure is that I am not a statistician. I'm completely a clinician. So this talk is entirely from a point of view of a clinician and what we need to know. So what is a statistical analysis plan? Let me go back. Any of you? What is a statistical analysis plan? Okay, so what's a statistical analysis plan? Maybe somebody who has not spoken, a lot of you have sat silently. Either you all are asleep or somebody who's not in my group. You. No, I'm not picking on you. Do you know what's a statistical analysis plan or?
Right. So
Perfect.
it is a plan wherein we summarize what is the design and method that we're going to follow that particular protocol for that particular.
Perfect. So it's part of the protocol or it's part of your publication? Where is it?
Part of the protocol.
Perfect. And that's exactly correct. So a statistical analysis plan is a plan that you're going to be doing. Sorry, it's not moving again. Yeah. So it's a very supposed to be a very comprehensive document, and it is supposed to describe everything that you're going to do once you're done with so starting with your planning to the end of when you're publishing your data. So it's a detailed technical description of the analysis that you're going to be performing. And it should contain in-depth description of every statistical method that you want to use. And you need to define the statistical output, which will be included in your clinical study report. So I'll give you a few examples of what our initial statistical analysis plan looked like. This was one of our very first studies, 2010. This was a pilot study to evaluate EGFR mutation status in Indian patients with lung cancer. There was absolutely no statistical analysis plan at all in the protocol. We had a sample size, which was also approximately what we think we could get. We published the paper, and this is the publication of the paper. So this is in the materials and methods. So if you can see the right bottom part of it. So we said we will carry it out in SPSS. We will check the difference in proportion with chi-square test. We'll use Kaplan-Meier for PFS and for OS. So that was our post hoc, I would say, statistical analysis plan. This was my first study that I had written when I joined TMH. So when I trained, I did lab research. So I had not done any clinical research. So I had absolutely zero idea of any clinical research protocol. And this was the first protocol that I wrote. This was the statistical analysis, and I have Vikram to thank for this. So the sample size, I don't know if you recall, you had done the sample size calculation, and Vikram was going to do the PK/PD for cisplatin. So he gave me these 3 lines, which I put in the protocol. Now, what we were trying to do is assess non-inferiority between 3-weekly cisplatin versus weekly cisplatin in combination with radiotherapy for patients with locally advanced head and neck cancer. What test to use? How would I assess the non-inferiority? How would I check if the data is normally distributed? Nothing. Absolutely, there was nothing in this. And it also goes to show that this is my IEC approved protocol. So nobody asked for it. I didn't know it was required, and nobody asked for it. So I completed the study, and all of us as true researchers think that this is the best study anyone could ever do. So we all sent it to NEJM the first time, right? So it came back, and the moment you send it to NEJM, it's like an auto response. You get, please send your protocol and please send your statistical analysis plan. So ye wapas aa gaya. I said, what on earth is a statistical analysis plan? So I'm looking in the protocol. There is absolutely nothing there. So we again made a post hoc statistical analysis plan, which I said, this is the statistical analysis we have performed on our data, and this is a description of what we have performed. They accepted it, thankfully, but there were other reasons. So what actually is a statistical analysis plan? And this is a very well-defined thing. So it has to contain technical, detailed elaboration of the principal features of the analysis described in the protocol, with detailed procedures for executing the statistical analysis of your primary, secondary variables and other data. So there are a lot of guidelines for how to write your protocol, how to write your paper. But a few years ago, there was actually no guidelines about how to make your statistical analysis plan. So this group of people came together to make these guidelines, which was published in JAMA. I'll go through this very briefly because of lack of time, but basically the initial part is your administrative part. So you'll say, what is the title? What is the version number? What is your date? And What are you going to be putting in an interim analysis or stopping guidelines? And when are you going to time your final analysis? So this is the initial administrative part of your statistical analysis plan. Then you have the statistical principles, and that is really the most important. So what are your p-values? What are you setting as your confidence intervals? What are you going to be stating are deviations, violations? What would constitute all of that? So that needs to be part of it. What is your analysis for? So what are your populations? Which are you going to use intention to treat? What is your efficacy population? What is your safety population? So you need to predefine all of this in your statistical analysis plan. Then the trial population part of your statistical analysis plan is what you are going to look at to make your consort diagram. So how are you going to do screening? What are you going to do with your screen failures? What will constitute your intention to treat population? Which patients would you exclude from your analysis? So that is your trial population. What will you do with withdrawals, follow-up, etc.? So that is your trial population. Sorry, I think I'm missing some slides. Did I do this? No, no. And then the analysis. So outcome definition. What is your primary outcome? What is your secondary outcome? What test are you going to do to test whether your hypothesis is correct? So initially you'll have your descriptive study. So the basic part is your administrative part, that whatever date, time, etc., name. Then you will say what is your population of interest. Then you will say when you have got your data, you need to look at it and say, is this normally distributed or not? And that you have to define. How will you check for normal distribution? If your data is normally distributed, then you're going to talk about your demographic details. Like, so I will check the demographics with simple descriptive statistics, percentages, proportions. Then your inferential statistics, and your inferential statistics are what you have defined as your primary and your secondary outcome, right? So is it a time to event? Is it a proportion? Are you going to use chi-square test? Are you going to use Kaplan-Meier? So that is the analysis part. And that's actually what is the crux of your statistical analysis plan. How will you deal with missing data? What will you use for censoring? And what software are you going to use? And then you put your references. So that's essentially what your statistical analysis plan should constitute. So any questions so far? Have any of you ever written a statistical analysis plan? No, I hadn't until like a couple of years ago. So no worries. So these are a little bit of a story of the problems that I have faced in my statistical analysis and statistical analysis plan. So first is the importance of defining a primary endpoint. And at least the ones of you who are in my group, I keep stressing on this. This is the most important. You need to be very clear in your mind what you are looking for at the end of your study. So I always say, close your eyes and imagine that your study has been published in Nature or in NEJM. What will be that first line, or that last line, the conclusion line? So in my study, I found that X intervention caused this in X number of people, and therefore this is why it is important. So what are you trying to answer? And that is your primary endpoint, right? So that is extremely important. So your specific objective and your hypothesis has to reflect your scientific question that you're asking. And if you provide it in sufficient detail in your initial protocol part of it, that's fine. If not, then you need an additional separate statistical analysis plan. And your trial hypothesis should be stated in complete detail. So you want to know the type of the study. So is it superiority or non-inferiority, the framework of the study, and the regions of your statistical testing. So is it a one-sided or a two-sided test that you're going to do? So this was the iron study story. This was written in 2007. So I joined TMH in 2009. So I bear no responsibility for this statistical analysis plan. But our initial primary objective was to determine the change in hemoglobin before compared to after 2 cycles of chemotherapy. So that would be 2 cycles of chemo, right? 3 weekly chemotherapy, and then so 6 weeks after. And we were comparing IV iron to oral iron in patients with cancer-induced iron deficiency anemia. So, and a secondary endpoint, so quality of life and need for RBC transfusion. So this was the paper. So I'm showing you my statistical analysis from the paper. I'm not sure if you can see, I can't. So our hypothesis was that IV iron administered to patients with cancer-related iron deficiency anemia would lead to a 20% difference in hematopoietic response compared to oral iron. And to prove that hypothesis with a type 1 error of 5% and a power of 80%, we needed 178 patients, assuming a binomial distribution, etc., etc. So fine, right? That looks like a reasonable statistical hypothesis and a reasonable plan. So we submitted it to supportive care in cancer, and we promptly got back a rejection because they told us that that the study was insufficiently powered to answer the study questions. Wait, I'll just show you. So this is the consort diagram. Do we have a pointer? Okay. So if you can see, we have randomized the number of patients that we had said that we would, right? One. Yeah. How to do this? Yeah. Can you all see properly? Is it my eyes or it's looking very fuzzy, no? So we randomized the correct number of patients, right? Whatever we said our sample size was, we had included those number of patients. What we didn't realize when we had planned it was that by 6 weeks, there will be all sorts of things that will happen. Patients will progress, so they are not on chemotherapy anymore. Patients will take blood transfusion. So if they get blood transfusion, clearly you cannot go by what the hemoglobin is. So they got excluded. Patients will withdraw from the study. Patients will go home. Patients will die. So eventually, Sorry. Maybe this is a postprandial problem, technical problems. So eventually, even though we had recruited the correct number of patients that gave us whatever power we wanted, the number of patients who we had analyzed was only about 140 patients. So, and that was absolutely not powered. So even though it looked like there might be a difference, it was actually a negative study. So, and that was the reason. So think carefully what is going to happen to your patients when you are planning your study. I think that's the bottom line. So eventually, yeah.
The acquisition has exceeded your expectation. When your study has lost its power again.
So it lost its power, yeah, absolutely. But if you're so
when you've already assigned them to the treatment.
No, so they were so you are absolutely correct if you're talking about a time to event survival analysis. But for you to include them in your analysis set, if you define your primary endpoint as a test that you're going to do at the end of the study, so our primary endpoint was the hemoglobin. Now, if the patient has died before that, clearly there's no hemoglobin, right? If the patient has transfused a blood transfusion, that is not their own hemoglobin level. So they were all excluded. So if you don't have a value, they cannot be part of your intent to treat however much you may want to, you may say that, right? You understand. So that's the importance of your primary endpoint. So make sure it's a clinically relevant as well as a primary endpoint that you will be able to test appropriately in the time frame that you're testing. And I think we have been discussing this with Dr. Abhijit and your study of cognitive dysfunction, and how can we possibly have those patients there for 3 months for you to be able to do that. So that you need to make sure that that's an appropriate primary endpoint. So I'm ending all of my examples because they're all a bit negative examples. They all ultimately got published. So this did get published just in a lower impact factor journal. So then the Chrome story. So this is similar to the study that you are doing, Babita. So the Chrome study is a randomized clinical trial evaluating the efficacy and safety of the addition of oral metronomic chemotherapy after completion of standard chemo-RT versus observation in CA esophagus and G junction cancers. So this was the protocol. This was our primary endpoint. So our primary endpoint was progression-free survival. Okay, no problem with that. Anyone has any concerns about that primary endpoint? And this was the definition. So what I'm showing you is a picture of the original protocol. So the primary endpoint was PFS. This was an integrated phase 2, phase 3 design. So PFS for the phase 2 part of it. And then if that was positive, then to go to the phase 3, which was OS. So I just put this in to say that the concept was so attractive that when we had initially planned the study, Cancer Letters solicited us to write a review article about what we were planning and the importance of oral metronomic chemotherapy in patients with gastroesophageal cancer. So Cancer Letters is a relatively good journal. And so they asked us to describe our study. So this is way before, okay? This is like 5 years ago when we were planning the study, we had published it as this is our plan and this is what we are planning to do. So we completed the study, submitted it to JAMA oncology, which said, no, we are not interested, transfer it to JAMA Network Open. We transferred it to JAMA Network Open. And this is, it got rejected in JAMA Network Open as well. And their concern was that we have called it progression-free survival. Now, these were patients who received chemoradiotherapy. So presumably, if they did not have evidence of disease, then how can you call it progression-free survival? And you need to call it disease-free survival because the patient doesn't have disease. So I said, okay. And I always internalize the comments of the reviewers. So I went back, and even though in my protocol it was written PFS, but I went and changed it in the paper to DFS, and I submitted to the next journal. So the next journal went to the reviewers, and the reviewer said, but how can you call it DFS? You need to call it PFS. So this has gone back and forth, and it is still with this journal. So I don't have a happy ending to tell you. Hopefully I will have next year. So yeah, this was my comments that, I changed it to PFS back again. Okay. So do we have some more time? No. Yeah. So this is my last example of the importance of defining a primary endpoint. So this is my 3-weekly story. The 3-weekly cisplatin compared to weekly cisplatin for CTRT for head and neck cancer. So this is my original protocol. The primary endpoint, now pay very close attention to what I've written in the protocol. Primary endpoint was loco-regional control. Bus. Is it a proportion? Is it a time to event? Is it, so I have not, this is it. That's my, and this is my definition. So loco-regional control defined as time from randomization to date of reappearance of tumor in the original tumor bed or the development of lymph node mets. Now, what does this sound like? Is it a proportion or time to event? This sounds like time to event. And I thought this is fine. Like this, I actually copied from the landmark trial. So that's what you do when you don't know actually what to write. You look back and see what the leaders have done and you write that. So I completed it. I sent it to JCO. This was the JCO biostatistician. So JCO does a very thorough reviewer process. So they send it to a proper biostatistician to go through what you have done. So the JCO reviewer said that your description of your primary endpoint is totally inconsistent. You have said somewhere that you're planning a time to from randomization to recurrence. And in the outcome, I reported it as 2-year loco-regional failure rate. No, I was also a champion. I also was confused what I was reporting. So I said, yes, I'm really sorry. I agree with you. I will change it. And then what we had called it was loco-regional control. But what I reported was loco-regional relapse, right? So in my mind, these two are kind of like, one is the reverse of the other, right? So if you have not relapse, you have control. So our team thought it was, by and large, it was the same thing. So and I'm trying to explain to them, it's the reciprocal of the other. It denotes the same thing. We will change whatever you want. We will change the terminology. So then the reviewer wrote back and said, you must be consistent. And by the way, whatever you have written in your protocol is absolutely different from what you are saying now. So and this is the problem. When you write your protocol, be really, really, really sure what you want to be checking. So I have said that failure was recorded as time to recurrence. Do you want to do time to event? Do you want to do proportion? Please be consistent and stick to what you have written in the protocol. So I said, this is what was done in the pivotal trial. This is what we took. In the pivotal trial, they called it loco-regional control. So we called it loco-regional control, even though what we were reporting was loco-regional recurrence. So we apologize for all this confusion and we have used it inconsistently. But what our intention was loco-regional control, and is it acceptable to you? So they said, no way, this is not acceptable. So this went back and forth. I'm telling you, I thought this is ye to gaya hi gaya. So this kept on going. It was at least a dozen communications between the reviewer and ourselves. And then finally the editor stepped in and said, you know what, I agree with my reviewer. You need to be consistent. So it went back and forth. And then I'll skip some of these. And then we changed it. I just wanted to tell you all that this article was actually solicited by JCO. Okay, so in spite of it being solicited, and so first they solicited it saying that please, when you're ready to submit an article, I hope that you will consider JCO as your final portal of publication. So I submitted to them and they almost rejected it. So in spite of this, it went back and forth, and because we were not very consistent in what we made in our statistical analysis plan, because we didn't have a statistical analysis plan, right? So eventually it got published. I think that's the happy ending to it. But since then, I always think very, very, very carefully and talk it over with all your team members that what you are trying to achieve has to be clear, consistent, and transparent. And the reason for that is that, once you complete your study, you can torture the data. And that's what happens. So because you have done, it's a very valuable information. And if you look back and then post hoc, you decide that, you know what, I'll do that test to try and figure this out. That's inappropriate, right? So you need to be transparent and upfront and a priori what your statistical analysis is. Okay, and this was something that I had briefly mentioned in our team. So in our group, so the importance of defining all possible objectives, and that's what I always say: secondary objectives, as many as possible, dal do. So this was weekly, 3 weekly. These were our objectives: loco-regional control, response rate, toxicity, compliance, PFS, OS, quality of life, and PKPD. I thought कि बहुत सारे लिखा है, जितना मुझे चाहिए I have written there. I didn't realize that I have forgotten DFS. So eventually DFS looks different. So I put DFS and I said, you know, this is a exploratory post hoc analysis, and I put a curve and everything. The editor replied saying, please निकाल दो, आपके protocol में नहीं है. If it is not in your protocol, you have no business analyzing it. Please remove it. So we did remove it. So again, anything that you want your data to answer, be sure you include it in your protocol somewhere. It can be a secondary objective, it can be a tertiary objective, it can be a quaternary objective. But if you have not defined it, then you really have no business reporting it. And even if you, and then we can say it's a post hoc, right? But anyway, your secondary objectives are all hypothesis generating. You're not calculating your sample size based on your secondary objectives. So they are all anyway hypothesis generating. So dal dijiye. So I think that's my moral of the story. The importance of defining events and censoring. This was this compromised small cell lung cancer. So I wanted to see, so there are certain chemosensitive tumors, right? Germ cell tumor, small cell lung cancer, jisko even patients who are PS3 or PS4, we try to treat them. Although in the literature, we don't have any data to say that this is actually appropriate. So in clinical practice, if the patient looks like they would tolerate it, we give them chemotherapy. So we thought, let's do a retrospective analysis as to what happened to these patients. So we wrote the protocol. This was the statistical analysis. And just pay attention to the definition of PFS and OS. So I said PFS from start of therapy to progression, either objectively or symptomatic deterioration or death, and OS from chemo to death from any cause. So I have not included any censoring here. So assumption is that if the patient is lost to follow-up or not contactable, you will censor those patients, right? That's the standard thing. So now, however, this was a retrospective study going back about 5 or 7 years. There were a fair number of patients we could not contact. Now, these patients had small cell, extensive brain mets, PS4, can't contact them for 5 years or 6 years. What is the assumption? I mean, the assumption is death. So I took a judgment call, and in this study, all patients I couldn't contact, I coded them as event occurred. Matlab they are death, because otherwise you are overestimating, right? You understand? So I submitted it to Acta Oncologica, and I wrote that. So if I found if they were lost to follow-up, I censored them as event occurred on the date that I last knew that I had last contacted them. So this was the decision. The reviewer said that this is a very bizarre thing that you're doing. Coding as dead on the date of the lost to follow-up is a very strange approach. Please go back to censoring them for lost to follow-up. So this Acta Oncologica is a European journal, and they don't know what our local problems are, right? So I wrote them a whole long discussion that, you know, we are a tertiary care cancer facility, patients come from far away, they take a local SIM card, they go back, they change their number. If we can't contact them for many times, for a long period of time, most likely they have expired. But they didn't accept it. So we did have to censor those patients. So again, I'm saying, make sure you put all those details in your statistical analysis plan. So I quote, sorry? Last date. So the last day that they were alive, but they were in a bad shape, I coded it as death. Right? So there are statistical methods. So this is the worst case scenario. So there are statistical methods that you look and see what is the time, and then you add a month or add 3 months or whatever. This is also a happy ending. It did get published in Acta Oncologica. So, okay, then a prepatent for cough. Sorry. So this was a thesis that we had given to our one of our students. So using a prepatent, which is an NK inhibitor, usually an antiemetic, but there was some evidence that the NK pathway was also important for cough in lung cancer. So drug repurposing of a prepatent for cough in lung cancer. So I think this was the statistical analysis plan. Okay, so whatever we put into the software to make a sample size, that got cut pasted, and that was our statistical analysis plan. And this was the primary objective. So take a look at the primary objective to study the effect of a aprepitant on subjective improvement in cough measured by the visual analog scale and Manchester cough in lung cancer scale. So these are two questionnaires. Visual analog scale is just 1 to 10. You have to put a mark. And Manchester lung cancer is like a 10 point. You have to just say, yes, you have cough. How does it affect you? But if you can anyone tell me what is wrong with this primary endpoint? Either or, how much, what will be positive? Kuch nahi. This is it, like to study the effect. So we submitted it to JCO. JCO said, we are really sorry, but we had multiple concerns about your specification of your primary outcome and the conduct of your primary outcome analysis. The reviewer, and this was based on what the reviewer had said. So the reviewer told us you had two primary endpoints, you had VAS and you had Manchester lung cancer scale. You didn't specify how to define the success of the study. Was it superiority of study drug in both outcomes? Anyone, either or? You evaluated your outcomes longitudinally. You didn't specify your primary point of interest. So we just did it at some 12 weeks or something. We decided. We had not actually written that. So again, I think eventually it got published in CHEST, which is impact factor 10. So we went from JCO, which is impact factor like 50 to 10. So it makes a difference, and it's not a matter of getting your paper published in the highest impact factor journal. The better the journal, the more you are able to impact people, because the more people read it. Right? I mean, there may be studies that I think are really, really important, but didn't get published in a good journal. So most people are not aware of that. So I think that's the bottom line. We are ultimately doing research to reach the widest audience so that you can make a difference, right? So Jeff, I think this is the last example. Jeff, this is a Jeff GC story. So we had done a study of in EGFR mutant lung cancer patients. The standard of care is osimertinib globally, but osimertinib costs about $1.5 lakh a month. So by and large, none of our patients can afford it. So we treat them with first generation oral TKIs, which are gefitinib. So we wanted to see if adding chemotherapy to gefitinib improved the outcomes. So we compared gefitinib to gefitinib plus chemotherapy. So this was the protocol. We submitted it to NEJM. Every time you submit it, your heart keeps, every morning you get up and you open the email like kuch aaya, and then you say, I am sorry, decision that I am sorry, and then so we are sorry, we could not accept it, and this was the reasons. So we had not specified the time of tumor assessment. So we said, and we always write very pragmatic studies because we want to do the maximum that we can do in our limited resources. So we said, and we'll do our tumor assessment, our CT scans, but 2 to 3 months. So they said PFS is your primary endpoint. How can you say 2 to 3 months, right? I mean, so somewhere you have done it 2 months, somewhere you have done it like 3.5 months. So that's not appropriate. As PFS is your primary endpoint, your description is not acceptable. In your statistical analysis, So in our statistical analysis, at that time, we used to calculate a sample size of patients. So we said 350 patients we will include. We didn't put the number of events. We also didn't say when we are going to do our analysis. So that's also an important thing for you to include. So the last patient was enrolled in August 2018 and data analysis took place in March 2019. Any idea what triggered my data analysis in March 2019? 1 year follow-up, no. No. What happens in March of every year? ASCO. So this was late breaking business. So ASCO, and that is an inappropriate way to decide to analyze your data, but that's what, because we didn't know any better, right? So normally you should say that after a certain number of events have occurred, I will do my analysis. ASCO aa gaya, date aa gaya, I did my analysis. So it eventually didn't get published in NEJM. It got published in JCO. So NEJM is 100 impact factor now, I think 9500. JCO is 50. So that's again the importance of putting a proper statistical analysis plan. And early pal care, I think I'll skip that because we need to get. Okay. So I wanted to give you all like last tips of advice from me beyond statistical analysis plan, because again, statistical analysis plan is not my forte, but research is my forte. So some general advice beyond statistics. If you want to be a researcher, and all of you are really bright, and I must say I've been very impressed by the quality of the thought process and the ideas and the ability to work from at least the people in my group and the others, whoever I've interacted with. But it takes a lot of patience. It takes a lot of resilience. Getting approval, regulatory approval, takes time. Now, this is a study that is very close to my heart. Some of you may know that geriatric oncology is, it's very close to my heart, and lung cancer is very close to my heart. So in June of 2020, I wrote a study optimizing chemotherapy in the first line for frail older patients with advanced lung cancer. Submitted it to IEC. This is a picture of my IEC portal. So if you see, the beginning is the start date. So, whenever you submit it, that's not the date you have started it, right? You probably have started at least 6 months ago, right? So this was planned in about a year ago. So 2019, it got submitted in 2020. Submitted date. So that submitted date is the last date that I have sent my last revision. The approved date is blank. Any idea why? It's not approved yet. So it is 2 years. It takes time. It will get approved eventually, but it takes time and you have to be patient. So it goes back and forth dozens of times. Be patient. It will. Yeah. We have independent institute IC. Once you get approval, and you will get approval, you have to just keep on banging your head and keep on responding. Once you get approval, funding is not easy. Whatever Jayant or Vikram may tell you that you get funding, you don't get funding. Okay, not for drug trials. So no, wait. I'll show you real information. So this is a study in CA penis. Now CA penis is an area of great therapeutic or research nihilism, because it is something that we see. It is not a global problem. It is an India-Asian problem. So this was a study. TRAC is our institutional funding body. So the institute didn't fund it. So that's the first step for us to get. So they said, no, we are really sorry. Apply to extramural funding. So I applied to DBT. This was the application. DBT rejected it. And the reason they rejected it is the following reason is we approached ICMR for further consideration. Now, was ICMR accepting? No. For the last since 20, so this was in 2019, okay? Since 2017, ICMR was not accepting any kind of research proposals. So you can see I took a picture of the website there to keep it for myself. So online submission of extramural concept proposals is on hold since 2017. It has started now, but at that time, there was no other option. I needed to get the study done. So I applied to all sorts of things, and all of this takes time, right? So I found some Paul Hamlin grant. I emailed him. I said, will your foundation give us a grant? They said, really not. I mean, we are like somewhere in the US. There is absolutely no way. So at the end of it, is it worth it? I think it is. I'm a big fan of Barack Obama, and he has this very inspiring catchphrase: the audacity of hope. Right? You hope to make a difference. That's why we are doing what we are doing, right? A belief that there will be better days, and what you are going to do is going to make things better. So I had written this write-up for cancer research in India, making a case for it. And as a clinician, you impact every patient that you see, right? But at the most, you will see 30, 40 new patients a day at the outer limit. As a researcher, so I'm taking example of Dr. DeCruz's N0 trial. So in Globocan 2012, there were 77,000 new oral cancer patients annually in India and 300,000 worldwide. Approximately, even if you say 30% of those are early oral cavity cancer, the number of patients that Dr. DeCruz's trial has impacted and saved lives is approximately 23,000 early stage oral cavity cancer patients in India annually and 90,000 patients globally. So this is the impact that you can do. And this is a study that I'm currently conducting, and I was looking for it because this is one of the Terry Fox funding grant. So in order to write for what is the impact of doing the study, I was looking up what else has been done. And I found this survey that was done about low-dose abiraterone in metastatic prostate cancer patients. And in that, there was this really nice paragraph on cost-effective analysis. So what we are doing is looking at low-dose abiraterone versus full dose, which is 1/4 of the dose. So if low dose abiraterone is actually efficacious and equi-efficacious to full dose abiraterone. This is the cost savings, right? So $3,640 over a patient's lifetime, which is 2.6 lakhs INR per patient, which is 2.5 times the mean GDP of India. So this is the impact that you can do, that one person and a team, one clinical team can do. So I'll end with what NCCN says. The best treatment of any patient is on a clinical trial. And that's what we all need to move towards. This is our chance at immortality, right? This, I don't know, I am not up to date with Marvel and all of that. I'm still in the Harry Potter thing, but you know, the Deathly Hallows and the Sorcerer's Stone. So this is your chance of immortality, right? You make a difference even if you're not here, right? Because what you are doing will make a difference forever. So I want to acknowledge our team. So this is our team. Dr. Kumar Prabhash is our leader and our head, and he has spearheaded all of the trials that I have shown you. The rest of our team, Dr. Vijay Patil, Dr. Nandini, Dr. Amit, and our newest member, Dr. Ajay. Okay, this is our molecular oncology team, our lab. These are my mentors. So in my training, I trained with Dr. Edward Chu. So he made me work in the lab. So I knew nothing about clinical research, but he inspired me to do research. And here my directors, Dr. Badwe and Dr. Banavdi, Tata Memorial Hospital, all the patients, my family for putting up with me. And I think lastly, that is my son. So I wanted to tell Vikram. Vikram is not here. So my poor son wanted to play. He's actually currently playing nationals. And I had already committed to Vikram that I'll be here. So he said, Mom, I want to go. So he's out playing nationals alone with some friend. He went with some random, he's 15, he's not a baby, but he went with some other random friend and he's in Nasik playing. So acknowledgements and thank you.